All right, good evening, everybody. Everything good on your end, Michaela?
Yep.
All right, you going to monitor that waiting room for stragglers?
Yes. Yep.
Awesome, thank you. All right, so good evening. Welcome to our August edition of the AHEC and District 4 webinar. We're going to talk a little bit about head injuries and concussions and stuff like that tonight. I'm going to be your presenter, so hopefully you will get something out of this. As I do with all of my presentations, open discussion. If you guys have questions, go ahead and put it in the chat box or ask it at the end. I am not an expert when it comes to concussions. I've done a lot of studying on them and a lot of research on them, and I've been to a lot of classes, just like most of you guys probably have. So I'm not going to put on like I am an expert on this and that I am the end all know all when it comes to this stuff. So any interjections would be greatly appreciated from you folks. A couple of things before we get started. Some dates to think about at the end of September. There is, for those of you that are firefighters, the Fall Firefighters Conference will be in Fort Pierre, South Dakota, at the end of September, first day of October. October 1, I think, is the main day for that. October 2nd is the Fallen Firefighters Memorial in Pierre. So if you're able to get to Fort Pierre for that, get that on your calendar. You can go to the South Dakota Firefighters Association website and get more information on that if you're interested in going to that. Also at the end of October, 29, 30, 31, we have the South Dakota EMS Association Conference in Sioux Falls at the Ramkota. That is fast approaching, and some phenomenal speakers lined up for that as well, like always. And if you are able to attend that, make plans to be there. You can find information for that out on the South Dakota EMS webpage, I do believe, or you can contact any of the state officers for more information on that. So with that, I think we're going to jump right into it unless anybody else had anything. Michaela, do you have anything at all?
Nope. I think we're good.
All right. So I'm going to, can you guys see my screen?
Yes. Yep.
You can see the presentation, correct?
Yes.
Okay. So I'm going to stop my video. All right. And slide over to this screen. So what we're going to talk about tonight is kind of a broad spectrum of this. And we are going to talk about a program that was developed in the mid 2000s coming into today. And the name of that is EPIC. And it's an EMS centered approach to head injuries. And when we talk about head injuries, we talk about 2.5 million emergency department visits annually in the United States. That's a lot. Traumatic head injuries. More than 10% of those head injuries are hospitalized, from which nearly 53,000 of those people end up dying, which is more than 1/3 of all injury-related deaths when we're talking head injuries. So when we're talking past versus present, and not so far into the past, really, and even to a point of I still see some of this stuff happening today, it's the thought, or it used to be the thought, that there was little that pre-hospital care providers could really do for our patients with head injuries. With new research and expanding partnerships, emergency trauma teams reveal that EMS can be very critical. This is rural field EMS can be really critical in improving outcomes for these patients. And some of the things that are out there is there's handheld brain scanners right now to be able to see if a patient has a brain bleed. And those are kind of more the cutting edge. You see a lot of those being used abroad. In London, some of their flight teams over there did a lot of studies on this from about 2015 to 2020. I haven't heard so much of this in our country, but I just maybe missed it. But they are out there. They can be used. Some of the more prevalent things in our part of the world is going to be early advanced care and early air support. So we are rural. There's no getting around that. And the earlier that we can distinguish that we have a head injury, we have a patient who's dealing with a traumatic head injury, the earlier we get advanced care called and the earlier we get air support called is going to be critical for that patient. When we talk about sports with head injuries, we're starting to see more advanced personnel on the sidelines. There are high school teams who have doctors on the sidelines, which those doctors can maybe start that process a little bit sooner and recognize it. But I'm not going to take anything away from our EMS providers who are working these sporting events, whether it be soccer, rodeo, ice hockey, football, whatever. Our EMS professionals are also getting better at recognizing these head injuries earlier on than what we used to. So what is EPIC? EPIC is excellence in pre-hospital injury care. And sounds pretty basic, pretty, that's not a huge, it's not some big acronym that we have to remember. It's really basic. And this was a project that was headed by Dr. Daniel Spate, University of Arizona, in cooperation with the Arizona Department of Health Services. So what this does is it focuses on clear, field-ready guidelines intended to make a significant difference in the lives of victims that have had traumatic head injuries. And how do we do that? Where do we go from there? Our patients who benefit from the EPIC treatment is going to be those who experience loss of consciousness, those who have a GCS, Glasgow Coma Scale of 14 or less, and anybody that has had a post-traumatic seizure, or if they've had multi-system trauma that requires intubation by our advanced care personnel or those basic services who are using the iGels out in the field. So those are patients who should benefit and should be getting the EPIC treatment. So the EPIC treatment, again, is really basic, and it focuses on initial trauma care that's centered around the 3 brain injury H-bombs, all right? So that's hypoxia, hyperventilation, and hypotension. So we're going to talk about each one of those as we're going through here. So hypoxia, due to the fact that any single episode of hypoxia can go ahead and it goes ahead and doubles the mortality chance of a head injured patient. What the EPIC program does is it recommends keeping that O2 saturation of head injury patients as close to 100% as we possibly can through early application of O2. So now some of you are thinking, well, I just learned that, we're not putting oxygen on a patient if they're sitting at 94. Well, what the EPIC program does, and I'm not trying to sell it, I'm not trying to say that it's the end all, best all thing out there, but what it has done through its research and through its studies is it's shown that those folks with those head injuries, those traumatic head injuries, when they get that high flow oxygen early on, even if they are above 90%, maybe they're above 94%, wherever your protocols are telling you, if we can get them as close to 100% as possible, they have a better outcome. Also keep in mind, especially when we're working on to establish that advanced airway on a patient who has a head injury, that process, as we're trying to get that tube or as we're sinking our iGel or whatever you have in your trucks, is that O2 saturation can drop. So making the cost of hypoxia sometimes not worth the benefit of that advanced airway. So kind of a trade-off that you have to think about as an EMT or as a advanced provider is, are we going to send our patient into that hypoxia range just to get that advanced airway? I mean, where is our trade-off at? Now, obviously, if that patient is not breathing well on their own, and we have that in our protocols that we need to go ahead and put that advanced airway in place. I mean, that's probably what you're going to do, but you have to have that nice balance in there to where we're not taking our patient to low oxygen levels just to get an advanced airway. So, remember those things. So right along with that is when we're talking hyperventilation, sometimes in that effort to prevent hypoxia, it can be easy to inadvertently hyperventilate our victim of head injury. So in fact, there were some recommendations, and there are some recommendations that have existed to hyperventilate some victims of severe traumatic brain injury under some circumstances. What this EPIC program has found in this EPIC study is to avoid that hyperventilation, because that ventilation, if you're ventilating too much of the patient's CO2, that can cause vasoconstriction. So what that also does is that can have an increase in our patient's mortality rate as well. Pay close attention to the ventilation rates, ventilation rate timers, pressure control BVMs, and then also monitoring that end-tidal CO2. That's probably going to be your biggest friend right here, your best friend, is getting end-tidal CO2 on your patients and keeping that between 34 and 45. So we can prevent further damage in those patients. So hypotension, even a brief episode of hypotension can more than double the mortality rate of our head injury patients as well. So our advanced personnel use caution when we are administering pain medications and sedatives, as they may rapidly drop that blood pressure. Also aggressively work to treat and prevent the hypotension. What the EPIC study recommends is an initial 1,000 milliliter bolus followed by repeat 500 milliliter boluses of fluid to maintain the systolic blood pressure greater than 90. So let's talk a little bit about this. So we have a patient, we're going to use football for an example because it's in full swing. So we're going to use football for an example. We're working EMS at a football game. We get called out on the field because we have a patient who has been hit in the head, maybe has experienced some loss of consciousness, maybe seizing, and we've seen that before, maybe having a major medical emergency right out there on the field. Well, what is our first reaction to do? Our first reaction is to scoop that patient up and get rolling. Well, what EPIC is maybe recommending, and I really kind of agree with this side of it, is why are we going to be in so much of a hurry out there on that field? Why do we not, if our patient is stable, if they're stable, if they've come to, but they have said that they've experienced a loss of consciousness, why are we in such a big hurry to start moving that patient around? Why don't we get our baseline set of vitals, get a blood pressure, get an O2 saturation, and see once where that patient is while they're laying on that turf or on that grass, so we can use that as a baseline as we're treating our patient, as we're sending them on to a higher level of care. So don't get in such a hurry to scoop that patient up, get them off the field. We're probably going to have to do some other things, probably take the helmet off, get a collar on and board them, however your protocols are going to play into this. But from experience, I have probably overlooked getting that first set of vitals while we're sitting out there on the field. So speaking from experience here, it may be beneficial to kind of keep that in your back pocket, that, hey, before we start moving this patient, before we start getting their heart rate up, why don't we go ahead and get a nice set of baselines of while they're laying out there on the field. Does anybody have any input on that? If you do, go ahead and unmute or put it in the chat. Everybody agrees with me? That's awesome. Anybody have anything to add on that? Any for or against? Or silence means Kyle, you're great, right? I guess. All right, we'll move on. So EPIC procedures for children, again, kids can benefit from that same early high flow O2 administration when we're dealing with a traumatic head injury. End-tidal CO2, again, should be between that 34 and 45. Ventilation rate should be appropriate for infants, approximately 24 beats or breaths per minute. Children, 20 breaths per minute. Hypotension, again, age appropriate. Minimum systolic blood pressure can be found on our Broslow tapes. Is going to be a good place to do that, or you can roughly calculate taking 70 plus 2 times the patient's age, and don't let that systolic blood pressure then fall below that number. That is going to be your lowest number that you want that systolic blood pressure to fall below. Epic procedures for geriatrics. A lot of times with our geriatric patients who are involved in trauma, we sometimes under triage them for head injuries. And those are things that can come around after the fact, because they do have, a lot of times these folks are going to be on some sort of blood thinner. And their neck muscles and everything have deteriorated to a certain point since they are in the geriatric age group. So their neck muscles maybe aren't able to hold their head up, and they've hit their head a different way than say an 18-year-old would. So let's consider age as a risk factor when we're talking about head injuries. We maybe don't necessarily need to have that big goose egg on the side of their head to start thinking about, does this patient have some sort of a head injury? Is it going to be because they hit their head on the floor? Is it going to be more of a whiplash type effect? All those things are things to think about when you go on that call where you have that patient who's fallen and, maybe they've injured a hip or they've injured a knee or a leg or whatever the case is don't overshoot that possibility for a head injury. So our geriatric patients often have those medical comorbidities that complicate that treatment. We may have to manage medical as well as trauma issues with our older patients. Just like, sure all of you know this, is we may have to go ahead and be working trauma and medical on the same patient. And our geriatrics are a lot of times those folks who we have to do that stuff on. So our references for that portion of the talk, there's a little bit left. I'm not going to let you guys out this early. Is the EMS 1 article by Lexapol. Ram Duckworth wrote that article. It's where I got a lot of that information from. And then these are also some of the references that came out of that article. So I'm going to try to make this work. Michaela, you're going to have to help me a little bit on this. I'm going to play this video. And I think to get sound, I'm going to have to do what?
You might need to reshare
Share sound.
Or reshare, or new share, and then click. I guess we'll see. If you just want to click the video first, that might be the easiest. And we can see where it goes. So you'll want to go new share on your screen.
Yep. I'm going to stop this quick, pause this. And while we're getting switched around, does anybody have any questions, comments, concerns so far? Okay, can you see the YouTube now?
Yes, and then there's no sounds, but
Yes,
so you might have
beautiful young
there you
girl
go.
from Nebraska.
Perfect.
Okay, you hear it there? I'm
Yes.
going to crank it up a little bit. That'll help. So we do have a. Okay, here we go.
High school student. I met her in May.
Can you guys all hear it?
This year, 2012.
Yes. Yep.
And the story is that back in April of 2010, she's a soccer player and a softball player. She headed the ball. And as soon as she headed the ball, she got a headache, felt nauseated, was unsteady on her feet.
I used to play sports, soccer and softball at my high school. I'm gonna be a senior. To be honest, I don't really remember much anymore, but like my freshman year, I played soccer and softball, and I don't really remember either of those seasons. So from what my coach said, there was just a hard ball that just came like darting at me. I guess I headed it and I scored, so that's good. But I don't remember anything actually.
She came back to the sideline. They decided that they would hold her out and repeat the baseline test that she had. She actually had a concussion baseline test. They repeated that. and found that she didn't do as well, and she did significantly worse, in fact, than she did at her baseline. So that, plus her symptoms, they held her out.
Red flags just popped up everywhere, so they knew I had a concussion.
Unfortunately, she continued to be active. She kept going to school, she kept exercising, she kept trying to play sports, even while having symptoms, which is the first no-no.
I definitely came back too soon from the first one and tried to play sports again, and I had lied, which is not good now, but I had lied to like my parents and to the trainer and said that I had felt better.
Well, they just try to work through it, right? They figure, you know, it isn't that bad. I can work through this, and I'll just continue to do what I normally do and try to work through this. I'll tough it out, so to speak, without realizing that the cognitive and the physical exertion that they put themselves through, when the brain is telling you, I can't handle this, it's going to tell you by increasing your headache, by causing nausea, sensitivity to light, sensitivity to noise, unsteadiness. You don't sleep well. You got irritability in your mood. You can't fight through that. So your brain is actually telling you, I can't handle the cognitive and the physical demands that you're placing on me until I recover from the injury that I just had.
I can't even like tell you. You don't really understand until you have it, but I would have from a 7 to a 10 headache daily, never go away, throbbing in my temples. That was for 2 years.
She really didn't have a waking moment where she was free of pain. And when you're not free of pain, that gives rise to a whole host of other symptoms. You don't sleep well. When you're sleep deprived, you're moody. When you have pain, you're moody, you're irritable. Just the sensory environment around us just drives them mad when they have continuous pain in their head.
I felt like I had lost my passion my whole life pretty much up till I got injured. And finding something different to do with my life was really difficult. And honestly, chronic pain is probably what most of that was from, but it was just so stressful having headaches all the time, and just, I honestly don't know. I tried to make myself happy, but it was hard. And everyone around me noticed my moods were different, like my friends, my family, everyone knew something was wrong. And it wasn't until I really snapped on my mom and I told her how I was really feeling that anyone knew at all how severe it was. And I had thought about suicide. I mean, I hadn't planned anything out. I just was like, it would be so much easier not being here. But now that I got help and everything, I feel much better.
So the next step was to get rid of the pain in her head. So with the appropriate therapy that we used, we got rid of the pain in her head. And lo and behold, when you got rid of all the symptoms she was having from the blood pressure and heart rate standpoint, and when you get rid of the pain in her head, many of the other symptoms just cleared up on their own.
It happened rather quickly. I was on some beta blockers that had helped. I just completely stopped working out. I rested. I didn't use my cell phone as much. I just pretty much laid off of stuff, and I felt better probably a few weeks after I returned home from the Mayo.
What delighted me, and you know, I got chills when I spoke with her father recently just to hear how well she was doing, how happy she was again. She's now the girl that he knew 2 years ago. So to give that back, to give that girl, give their daughter back to that family, there's nothing more gratifying from a physician's perspective.
Well, the advice I would give other athletes would be, if you feel anything weird after any blows to the head, to stop. It's not worth it. Like, if you feel anything at all, honestly. And don't lie about it like I did. Don't lie about how you feel, because I thought it would put me back into the sports field sooner, but it actually set me back and made it worse, so.
All right, so we hear that a lot, don't we? We hear that a lot about maybe they're fibbing a little bit and they're to get back on the field, and then we get that second one, and then we have that catastrophic secondary type of an injury. So those are things that we may get called to where our patient might be in severe distress. They might be unconscious, they may be seizing, they may be not breathing. Those are all things that's probably where we're going to get called to if it's not going to happen out on the field. If it's something that happens just on a regular type of a routine type of a thing that those kids are doing, and it could trigger that secondary catastrophic type of an injury. So questions on our end. Has the patient hit their head recently? Have they been treated for a concussion? Those are all things that we need to keep in mind as well. Can you guys see the presentation again?
Yes. Yep.
So I like that video. It's short. It talks about having that secondary type concussion that really put that girl back. She says she does not remember her freshman year of high school because of the injury that she sustained. And we hear about that and see that more often than we really want to. I think that the South Dakota High School Activity Association has kind of corrected some of the issues in their concussion testing that has allowed the kids to supersede those or beat the tests. That was something early on that there were some issues with that kids were able to beat the test, so to say. I think that those issues have been fixed, and now it's more or less just the awareness and the training that our coaches and our folks on the sidelines have that are going to continue to keep concussions and head injuries in the forefront. So by the numbers, the top 10 sports, so it's 11, but there's a tie here, top 11 sports, I guess, for concussions in athletes under the age of 18. Rugby, as could be expected. Ice hockey, very common one where we see concussions. American football, lacrosse, soccer, wrestling, basketball, softball, and field hockey are actually tied. Baseball, cheerleading, and volleyball. So there's a lot of different stats out there. And cheerleading, competitive cheerleading, in some of these polls actually jumps into the top 5 because of the falls that some of those athletes take. So just because it's just cheerleading, some people might say, is that's an extremely dangerous sport as well. And you look at these, and we do ambulance standby for football because we think football is just so dangerous. We don't do standbys for a lot of these other ones. So we may not be there right away, and that could also affect the outcome of those patients. So, keep that in mind, that it's not just going to be football in South Dakota that's going to cause these concussions and these head injuries. It can be any one of these sports. And we've also seen quite a few in the pole vaulters and the track and field side of things. And they do wear helmets. I think most of them do anyways, and maybe it's a rule. I'm not up on track rules, but I know I've seen a number of those kids who are pole vaulters wearing helmets, but the helmets will only protect them so much when they fall from that great of a height onto whether it's concrete, asphalt, even the hard ground, depending on where their jumping pits are set up. Usually I think it's more of an asphalt or even just that track type setup. So very hard surface that they're falling onto. So Friday Night Lights started last week in the smaller schools. We got our large schools jumping on board this week. So full slate of football across the state starting tomorrow night. Also seeing college kickoff tonight. So we've got a lot of football being played in South Dakota going to be over the next 8 to 10 weeks. So I don't know where this picture came from. It came out of the Mitchell newspaper. So if this is your team, you guys got a good shout out. I don't know who these teams are. Came out of the Mitchell newspaper. So anyways, are you guys ready for some South Dakota high school football? When we talk about it, much like the EPIC program that we discussed earlier, we need to keep in mind what we can do on the field when we have an athlete that is suspected of sustaining a concussion. Use those 3 H-bombs. Get that set of vitals right away. Get that BP, get that O2 saturation, see where our patient's sitting at before we get our patient up and move them off the field, or we get them out of the stretcher, or however the injury is going to dictate how we take care of our patients. That set of vitals is going to be a very good baseline for us, and if we're transferring that patient to a higher level of care. Some of these patients, we may not be the ones who are transferring them. I've seen it multiple times, just like I'm sure all you guys have, is we'll get called to the sidelines, maybe at halftime or whatever, for somebody that got their bell rung, and we'll run them through some tests and take a look at them, and they're relatively stable, and they might stand over on the sideline the rest of the game and then go to the hospital or to the ER afterwards, or maybe not even go to the ER. They know they've got their concussion and it's more of a minor one. But those are the folks that we may not be transporting. We can go ahead and get our vitals and all that good stuff on those kids that we're actually going to be transporting, or we're going to be handing off to another ambulance service that might be coming to the game to pick them up. But those kids that we don't get called to the sideline for, we just get called to check on them. We don't have a lot of interaction with them, and we really don't really know what their outcome is going to be. So be an advocate for that athlete. When we get through a couple of these here, I'm going to talk about a situation that I had last week while I was doing ambulance standby at a football game. So have a relationship with the coach. Make sure that coach knows what we're going to do when we come on the field. Make sure that coach knows that we're going to go ahead and get vitals, or if that's what your protocols are telling you to do. Understand have that relationship so they understand what we're going to do, and then we also understand, their perspective of it. Be vocal to the coach and the athlete when giving advice. Also involve the parents as much as we can when it comes to a patient who has maybe a loss of consciousness, or is really exhibiting those signs and symptoms of more of a moderate type of a concussion. Get the parents involved, make sure that they understand. And also what we're going to want to do there is just state the facts. We want to be professional. We want to have the best interest of that patient in mind, not if our football team is going to get a W that week. Little story about last week. I'm not going to get into the teams that I was doing standby for because it's not really pertinent to this little conversation. But for the first time in 20 years of doing ambulance standby, from 9B all the way up to NCAA Division II football standbys over those 20-year span, I ended up on the field rendering care to a patient. Now, that patient did not have a head injury, luckily, but what I heard from the coach really bugged me, and that's why I'm sharing it with you guys, is the patient that we had on the field had a dislocated limb. We're just going to say that. Dislocated, separated, however you want to say it. Patient was in severe pain. We got onto the field. The trainer told me, hey, we don't do anything with this. I said, hey, we're not going to either. So if they wanted us to transport them, we would have done that. We would have helped get them up off the field, but we weren't going to pop that back into place. In the motions of trying to get that patient up off the field, that separated area popped back into place. Patient's pain was gone. They felt a lot better. They were really excited that they didn't have the severe pain that they had just prior to that popping back in place. And the coach said, all right, get up, rub some dirt on it so we can get you back in there. This happened literally last Friday night. And my partner who I was with is a former college football player. And I think he could probably just feel my distaste for that comment. And he turned to the coach and said, no, this young man is done for the night. He needs to get that limb looked at to make sure that we don't have any pinched nerves or anything like that in there. He is done for the night. The coach backtracked, said he was just kidding. I find that hard to believe. So you're still running into this stuff where getting that W and having one of your better players on the field is sometimes more important. The competitive nature is sometimes more important than the health of that patient. So we have to be advocates for those athletes. The coaches are doing their job, so then we have to do ours. We have to make sure that we're stating facts, that we are getting that information to the coach, to the player, and to the parents of what possibly could happen in any type of injury, and making sure that they're making the best informed decisions that they can. So just some pictures here of some instances that I'm almost positive probably caused concussions, and different types of hits These are all football hits, and it appears that 2 of them are NFL, 1 of them is a college hit. This one here looks like a player was probably coming across the middle, maybe tried to make a catch, defensive back, hit them, and as you can see, his head gets bent back, flexed back, and it's probably going to hit the turf. So this guy, more than likely, going to end up with a concussion. This guy here, you can see 2 helmets each side of the head. He is probably going to end up with some issues going on there for sure. And this one right here, more than likely another whiplash type effect, where the guy in the Raiders jersey here, he probably maybe made a catch or attempted to make a catch. Defensive back hits him, his head flies back, comes forward, helmet flies off. Now he's going to have a tertiary hit here as well when his head hits the playing field as well on this. So the initial one was the whiplash going back. The secondary hit was when his head came back forward, and then the tertiary is when he's hitting the ground. So 3 hits here, again, both sides of the head here. This one is going to be you have your initial, and then you have your secondary of where he's probably going to hit the turf with his head. So these type of things, sometimes you're going to be able to see them when you're standing on the sidelines, and you're going to be like, okay, yeah, that kid's probably going to have a concussion. Some of them aren't as obvious as these hits are. I remember back to, I think it was the 2010 baseball season. For those of you that know me well, big Minnesota Twins fan. Favorite player, Justin Morneau, slid into second base, got a very slight knee to the side of his head on a shortstop coming across to complete a double play. That very minor hit that nobody really saw until they slowed it way down caused a career-altering concussion to a professional athlete. So these are all like, oh my gosh, we see those. Some of those smaller type hits, or not direct type hits, but they just hit in the exact right spot, are some of the ones that can cause the most damage that nobody ever really is like, oh, really, I didn't even see that happen. So be on your toes, and obviously, take care of our patient, treat our patient, treat our patient's symptoms, treat them as they're presented to us. There's been a lot of new advancements in equipment. As you can see here, these guys look like they're Star Wars guys or something, but these are what they call Guardian caps. And those Guardian caps are made to go over top of the helmet, as you can see here. And what it does is it reduces the energy of impact, and it's supposed to limit head injuries. So you're seeing these trickle on down to NCAA. I noticed the other night when I was watching a preseason story on a team in South Dakota, that all their linemen were wearing these soft Guardian caps. So you're probably going to see this more often than not. I have not seen it yet at the high school level, but I'm sure it's out there. Just me personally, I haven't seen it, but you're seeing it in the NFL, and you're seeing it in the NCAA ranks pretty widely. And they're supposed to limit the head injuries because they're reducing that energy of impact. Some other products that are out there, flexible type helmets. Rydell is making an Axiom helmet, and that's aimed at combating concussions. It's a little bit different material with a little bit different innards to it. There's some flex to it that's supposed to absorb those big hits that are helmet to helmet or helmet to knee or helmet to ground. The absorption is going to be there to grab hold of some of that energy and spread it out so it's not going right into the athlete's head. Many others that are too numerous to mention that are out there, but I mean, you do a Google search, you'll be able to find all sorts of them. There's a lot of different groups that are working on equipment that is going to and has helped the sport make their athletes safer. So another good thing to think about is get into that football closet before they hand equipment out in the fall and take a look at some of those helmets. Take a look at some of that equipment they're putting athletes in, so you are aware of, you know, the actual what it's trying to do, and then you're also aware of how do we get this off of our patients if we have to as well. So, two reasons why you need to kind of look at the equipment that's out there in your area. So, in closing, and we'll open it up for questions and comments. I hope you guys have some. You know, recognize that a patient may have sustained a concussion. Recognize it. Obtain that set of vitals on the field before we move a patient if we can. Have that relationship with the coach. Understand the concussion protocol that the South Dakota High School Activities Association uses. And it may be a good idea to even sit in on some of those trainings that some of your coaches have to sit in on. The coaches have to do concussion protocol training every year to stay on top of the new advancements and the new things that are out there. Be an advocate for your patient. Be an advocate for that athlete on the field. Understand the technology is being used in your school. So have that meeting with your coaches before the season starts. Take a look at the equipment. Understand how to get it off if you need to get it off a patient. Understand what its role is in protecting that patient. And that'll also help you in the mechanism of injury side of things. Is if we have an understanding of the equipment that's being used to keep those players safe, and we have an injury to those players, we may be able to use what we've learned about the equipment to further our mechanism of injury investigation as we're going through our patient assessment. All right, so anybody, questions, comments, concerns? Is anybody still awake? Do we have anybody still awake on the call? Is there anybody that wants to unmute and say hi?
Yes, hello.
There we go. We got one. Awesome. Does anybody have anything that they'd like to add to this talk at all?
It looks like we have some comment in the chat that says, I have told it is safer not to remove the helmet on the field as it could compound the injury.
That is a very good question, a very good comment. So it's going to be based on injury by injury. There's not a catch-all for that. So it's all going to be based on the injury. So the way the helmets are made today, if you get into your school and you see those helmets and you understand them, those helmets may be able to actually provide some head and neck support to our patient as we're maybe having to board and get those patients on a backboard and then onto a stretcher. Now, you need to know how to take those helmets off, because if you have a patient whose airway is compromised, that helmet needs to come off, because we're not going to be able to breathe for that patient or help that patient breathe while that helmet is still on. So whether that's just learning how to take off the face mask or learning how to take off the helmet, that is something that needs to be practiced. Should be every year. That should be an August or July in-service that you have with your service. And if you have a football team that you're going to be doing standbys for, is get a helmet, bribe a kid with something to come and be your live mannequin, and try to get that helmet off and try to maintain C-spine and all that good stuff.
Okay, it looks like there's another comment. Have to keep in mind that the players have shoulder pads, so if you remove the helmet, we'll need to have towels and support the head.
Yep, it's all a progression with the football equipment. That's a very good comment. That's why it's so good to use a real live mannequin wearing their full getup and trying to figure out how you're going to make that patient comfortable, and also how you're going to be able to maintain that C-spine. Because just like Kelly said, once you pull that helmet off, now you've got those bulky shoulder pads that are potentially in our way. Are we going to need to get those off? How are we going to do that? All that stuff comes into play. So yeah, anything else that anybody else has.
Kyle, can you hear Bell?
Yeah.
Okay, I got two comments. Number one is like you just got through talking about, I'm not going to get into dates and this sort of thing. I was working ER one night and a football player came in, and literally between removing the helmet and removing the pads, it took everybody in the ER, which was not many, of course, but on the other hand, the doctor did a very good job. I'm not going to mention names, that's wrong. Anyways, I got to watch my mouth here. The patient did end up flying out of here Aberdeen, excuse me, because it was a bad neck injury that was going to go into a head injury. That's as deep as I'm going to get into it. So what I'm trying to say there, it took us 2 hours to get the pads off. Now I need to add one more thing here. Am I allowed that?
Sure.
Okay, here we go. I noticed tonight we have been zoning in on football, sports. Okay, we need to back up here a little bit, and I'm not trying to be bossy, but reference a fall of a geriatric patient. There's a neat blood thinner out there called Eliquis. The neat part about that is the patients don't have to go in every 2 weeks to a month to get a blood draw, because Eliquis is 5 milligrams. My mom was on it. It worked well. But the whole thing is if you can get a pharmaceutical drug sheet that says this patient is on Eliquis, you need to, I'm going to watch my mouth here again, haul butt to the ER, because there really isn't a oh gosh, I can't think of the word I want because I'm talking online. Eliquis, if they start brain bleeding or wherever they start bleeding, that patient is in big trouble. And
Yep.
I'm done right there.
Yeah, and we talked about that a little bit through that first portion, and with the EPIC program is our geriatrics definitely do get under triage sometimes when it comes to our head injuries and even just possibilities for bleeds overall. So yeah, thanks for bringing that up. Anybody else? All right, seeing none, we will call it a night there. Do we have any sort of survey or anything? Nope. Okay. No survey at the end. We will be back next month, September 29th.
Yep. With farm emergencies. So-
Farm emergencies. We will be getting right into harvest time, and we'll talk a little bit about some of those things that we'll need to take care of. Yeah, if you did not sign up on the portal, go ahead and put your EMS number in the chat and we'll take care of that. If you did not sign up through the portal. So 2 places to sign up when you signed up was EMS portal and then also on the AHEC website. So, and just one other quick thing before we let you guys go tonight is we're talking about some changes that we're going to be doing potentially to our webinars. So stay tuned for that. Too early to really kind of talk about, exactly what we're thinking, but we have to keep evolving to keep this a viable resource for education. So if you get some emails or you hear some things in the coming months, just ask you to embrace and hopefully we will, be able to reach the most people that we possibly can. So, all right. Anybody else? Anything for the good of the order? Again, can't stress enough, try to get to EMS conference at the end of October, get signed up, get there. I think they're going to have a virtual option as well if you can't make it in person. So get there. All right. With that, we'll call it a night. Hope everybody has a good last last week of August, and we're getting into fall. We're getting into the busy fall season, and hopefully y'all stay safe, and we'll see y'all again next month.